Hello guys, this is Atfawi from the Match Guy QBank team, and I'm here with you today to break down some of high-yield questions in our QBank. So I want you to give attention, I want you to read and listen carefully to me, and I want you to put your answer down in the comments, okay? So now let's start. And I advise you guys to start with the last sentence because the last sentence is your guide. It will tell you what you want and what you are looking for in the case here. So the last sentence here is which of the following mechanisms best explains this patient's acute symptoms? So here we are looking for the mechanism. Okay. Now let's read the case together. 54 years old woman comes to the emergency department because of wheezing and shortness of breath. Okay. It began 45 minutes after she took an over-the-counter medication for a headache. And she had a history of asthma that has been difficult to control by daily inhaled corticosteroids and long-acting bronchodilators. And over the past year, she has also had progressive nasal congestion and decreased sense of smell, and has required two procedures to remove recurrent nasal growths. Okay. She doesn't have urticaria or pruritus. Okay. She has no known food allergies. Temperature is 37, blood pressure is 128 over 78, pulse is 104, respirations are 22, and oxygen saturation is 93 in room air. And physical examination shows diffuse expiratory wheezes, nice, and vaginasal mucosa, nice. Which of the following mechanisms best explain this patient's acute symptoms? Okay, now let's read the choices together to figure out the right one for our case here. So the first one here is COX inhibition-mediated leukotriene overproduction. Okay, this one here, guys, is describing the mechanism of action of aspirin and other non-steroidal anti-inflammatory drugs. And actually, we have something called, I don't know if you know about it or not, but it is called aspirin exacerbated respiratory disease, or AERD. And in this disease, we have asthma that is difficult to control, and this asthma is actually induced by aspirin or other non-steroidal anti-inflammatory drugs, which can explain medication over the counter here for the headache. It may be a painkiller. And the third thing in this disease is it is characterized by recurrent nasal polyps. And this also can explain the recurrent nasal growths we have in this patient here. So this one actually is a good one. So let's keep it in mind, okay? Okay. Second one is decreased bradykinin degradation. Okay, this one is describing the mechanism of action of ACE inhibitors. And ACE inhibitors, we usually don't take ACE inhibitors as a painkillers for a headache. And also we have something called hereditary angioedema. And this disease is characterized by the recurrent swelling in the airways and GI tracts and the skin. And it presents in patients with C1 esterase inhibitor. This is important also. But we don't have any of these symptoms here in the case, so choice B is not the best answer in our case here. And choice C, IgE-mediated mast cell degranulation. Okay, this one here is describing the mechanism of action or the mechanism of type 1 hypersensitivity reactions. And in type 1 hypersensitivity reaction, we have diseases like asthma. But here, guys, we have the asthma that's difficult to control, and she is taking daily inhaled corticosteroids and long-acting bronchodilator. If there's a normal asthma or a normal allergy, it will be easily treated with corticosteroids. And also here, in the case, we have something that make you easily exclude it being a type 1 hypersensitivity reaction or an allergy or true asthma. Do you know, guys, what I'm talking about? Do you know, guys, what is the sentence in the case that tells you that it is not a true allergy? This case here, guys. She doesn't have urticaria or pruritus. In true allergy or in type 1 hypersensitivity reaction, we can distinguish it by the urticaria and pruritus. And absence of these symptoms here tells you that it is not a true asthma. And also at the same time, difficult to control with the normal asthma medications tells you it is different mechanism than this mechanism here. So it is not IgE-mediated mast cell degranulation. This one is not the best answer here. D. Chronic M3 receptor blockage. Okay. This mechanism is describing the mechanism of action of anticholinergic drugs. And actually, anticholinergic drugs are bronchodilators. It opens the airways and it make you breathe easily. And we have medications that we are using for treating asthma like ipratropium or tiotropium. and they are working by this mechanism, and we are using them for treating asthma rather than causing asthma. Okay, so choice D also is not the best one for our case here. And choice E, phosphodiesterase inhibition. Also, phosphodiesterase inhibition is a mechanism of action of a drug that we use for treating asthma, and this drug is thiophelin. And when we inhibit phosphodiesterase enzyme, we increase the cyclic AMP. And increasing the cyclic AMP will lead to bronchodilation, and it will make you breathe easily, and it will treat rather than cause the asthma symptoms. The choice E also is not the best answer here. So the best one for our case here is the choice A. Okay, so I will pick this one, and let's see. Yes, this is the right one here. So guys, let's talk more about aspirin, exacerbated respiratory disease, or AERD. Okay, let's first discuss the mechanism or the arachidonic acid pathway, because if we understand this pathway, we will understand everything about this disease. So here, as we see in the image, we have arachidonic acid. And we have two main pathways for arachidonic acid. We have the COX-1 pathway, 5-lipoxygenase pathway. In COX-1 pathway, we are using arachidonic acid to produce prostaglandins. And the prostaglandins, especially prostaglandin E2, cause bronchodilation. It opens the airway, so you can breathe all the air in the room, and it will make you feel like you are amazing. And the second pathway is the 5-lipoxygenase. And in this enzyme, in this pathway, we are using arachidonic acid to produce leukotrienes. And leukotrienes are strong bronchoconstrictors. So we don't want this to fill out our blood. So what happens when you take aspirin and non-steroidal anti-inflammatory drugs that this inhibits this pathway? They inhibit the COX pathway. So the production of prostaglandin will decrease, and it will decrease its effect on bronchodilation of the airways. So, and at the same time, it will shift all the arachidonic acid to the other pathway, which is a 5-lipoxygenase pathway. And this will lead to a huge increase in leukotrienes production, and this will lead to a strong bronchoconstriction and a viscous mucus secretion, and this will make the patient feel like if he is taking his breath through the needle hole, so he is taking his breath very, very difficulty. So this is our mechanism here for the aspirin and the non-steroidal anti-inflammatory drugs in AERD. And if you notice, guys, while I'm talking, I don't mention anything about IgE, about basophils, about mast cells, because, or anything about the true asthma, because here we have a different mechanism. This is called pseudo allergy, not a true allergy. In true allergy, we have IgE and antibody, and this may be induced by mast cells and affects basophils to secrete some immune mediators that can cause asthma symptoms. But here we have a different mechanism. And also one of the most common things about AERD here, guys, is the nasal polyps. And this here, guys, explain the recurrent nasal growth in the patient, in the case. And we have asthma that is difficult to control, and it is triggered by aspirin. So when we inhibit the COX, we decrease the prostaglandins, we increase the leukotrienes, and it leads to bronchospasm. And that's why, guys, it was not easily treated with corticosteroids, because it is not an immune reaction. So in this case here, guys, we are treating this type of disease with two groups of medication. The first one is called leukotriene receptors antagonist. In this drug, we are inhibiting the effect of leukotrienes in its receptors, and these drugs are like montelukast and efileucast. And we have another group of medication that is called 5-lipoxygenase inhibitors. And this is like zilbetone. Here we are inhibiting the enzyme here. So we cannot produce leukotrienes and we cannot have bronchitis. So this is the way we are treating bronchoconstriction in patients with AERD, guys. Now, guys, and if you have any question about our case here, if you have any question, write it in the group, and we will answer it in the next session. And see you guys in the next one. Thank you, guys, and have a nice day.